I think we got time. We got like 10. This could be quick. So we're also getting into what I call carbon monoxide season as well. So we're getting into flu season, and we're also going to start getting into carbon monoxide season when we're going to start seeing it. So carbon monoxide, it's the leading cause of poison death still in the United States. Or accidental poison death, I guess I should say. But anyway, carbon monoxide is a colorless, odorless, tasteless gas. And it causes about 15,000 emergency room visits per year and 500 deaths each year. It's dangerous because as it is inhaled, it replaces oxygen in the bloodstream with the carbon monoxide molecule poison. And at high concentrations, the gas starves your vital organs of oxygen, such as the brain and the heart. And we'll skip the video, I don't think we need to see it. So carbon monoxide poisoning. It's called a systemic chemical asphyxia. Basically, it interferes with the transport of oxygen. Your red blood cells transporting oxygen to your tissues. It forms from the combustion of carbon material like wood. Oxygen is depleted in an oxygen, material in oxygen depleted environment, right? So colorless and odorless. House fires, burning house, burning furniture. It's also found with gas leaks and car exhausts. Common place where you get carbon monoxide. The mechanism of action. Oh, with gas leaks, it's kind of interesting because you can sometimes smell a gas leak, and I think the fireman could speak this better than I could. But it's not carbon monoxide you smell. I think it's something that's put in the gas that you actually smell. Is that right? I think I read that somewhere. So when you smell a gas leak, you got to be worried about carbon monoxide, but it's not actually carbon monoxide you're smelling. It's something that's put in the gas. Yeah, to let you know that it's leaking. So mechanism of action, it binds to hemoglobin in your red blood cells and prevents red blood cells from releasing oxygen in tissues. The treatment, it's oxygen, and it's high dose oxygen. So anyone who you're concerned about carbon monoxide poisoning, put them on a non-rebreather, 100%. Even if their SATs are 100%. In fact, if your SATs are 100%, is it possible to be severely toxic from carbon monoxide? Yeah, it tricks the pulse oximeter. It can't detect the difference between a red blood cell bound with carbon monoxide and a red blood cell bound with oxygen. To most pulse oximeters, they look the same. There are special ones that can distinguish the difference, but to your everyday pulse oximeter, it'll look exactly the same. So your pulse oximeter will read 100%, 96%, even though your tissues are severely hypoxic, not getting enough oxygen. Oxygen decreases the elimination time of carbon monoxide out of the body, so you're able to get carbon monoxide out of your body faster if you're just flooded with oxygen. We already talked about that last week.
CPAP help?
It's kind of interesting because that's actually what I like to do. The only problem is a lot of people who are severely toxic with carbon monoxide, they're throwing up. But I like, if you're not throwing up and you're not feeling nauseous and you appear to me to be severely carbon monoxide toxic, I kind of like the idea of having a CPAP mask delivering 100% oxygen because you think about a non-rebreather, it's not really giving you 100% oxygen because it's leaking around the sides of the mask. You're probably more like getting about 70%, maybe 80% oxygen with those things. It's not 100%. We say it is. We're giving them 100% oxygen on a non-rebreather, but it's not. It's more like 70 or 80%. With a CPAP, where you actually get the seal and you can control exactly what percentage you want, now you're getting closer to 100% oxygen. So the only problem with this specific type of toxin, like I said, is there's a good chance you're throwing up or about to. And that's a contraindication to CPAP. You don't want to put somebody who's throwing up on CPAP. So I like the idea in theory. It's just in actual practice, they usually can't do it because they're throwing up.
What signs and symptoms are you looking for if you take out the nausea and vomiting and, you've got 100% of your pulse?
Yeah,
What are you looking for?
Headache?
It's on here somewhere. We'll get to it. Yeah,
Okay.
2 slides down. All right, so this is stuff you don't need to know. I like it because I find it interesting. But so carbon monoxide pathology. This is a picture of your red blood cell, and then you've got 4 hemoglobin proteins that make up your red blood cell. Carbon monoxide binds very tightly to the hemoglobin molecule. That's usually where your oxygen is going to bind to. Your red blood cell would prefer bind to carbon monoxide about 1,000 times more than it would prefer bind to oxygen. It likes carbon monoxide more. It just has a stronger affinity for it. It wants to bind to it. So even if your red blood cell is bound to oxygen, it will let go of the oxygen to bind to carbon monoxide. So it inhibits delivery of oxygen to what's called the electron transport chain. And again, this is a bunch of stuff you don't need to know, but basically, this is the power producing factory in your cells. If this factory gets shut down, you're going to start getting organ death, because every cell in your body has this factory producing energy for your cells. And what happens is, if you can't provide this factory with oxygen, then it shuts down, and you're no longer providing energy. And that's why carbon monoxide affects pretty much every system in your whole body, because every system in your whole body uses this to produce energy. And again, one of the components that this factory needs to work is oxygen. Okay? And when you've got a lot of red blood cells that are bound with carbon monoxide and they're not delivering oxygen like they should be, this shuts down and you stop producing ATP, which is the energy your cells need in order to work. So, at any rate, the body can no longer make sufficient energy. It can't make ATP because the whole factory assembly line is shut down. It's not getting oxygen. Okay, so signs and symptoms of toxicity. Hopefully this will answer your question. It's really hard. Carbon monoxide can look like a bunch of things. You kind of really have to have a high index of suspicion and really kind of be thinking about it. But mild toxicity, nausea, dizziness, drowsiness. I mean, I can think of like 50 things that can cause this, but you know, that's mild toxicity. Moderate toxicity, you're starting to lose consciousness. You know, as your brain starts to become oxygen starved, you will start to convulse, you will have seizures. Again, vomiting, maybe cyanosis. A lot of times you're actually kind of cherry red, but you know, cyanosis, severe toxicity, you're going to a deep coma. Again, your brain is really depleted of oxygen now, dilated, non-reactive pupils, another sign your brain's not getting sufficient oxygen, deteriorating cardiorespiratory function.
I was just trying to find something on there that would let you know that to go that direction that didn't have contraindication to CPAP, because on almost all of those, I mean, you got a very, very small window that you'd be able to figure that out and actually use the CPAP.
Right. I think it's going to be unlikely that you're actually in real life using CPAP for carbon monoxide. I think you're most likely going to be using a non-rebreather. Although I think in theory it's a good idea, because you are delivering a higher concentration of oxygen.
Could you give Zofran for the nausea vomiting?
Oh yeah, most definitely. I encourage you. I think you should. So there are a couple different ways you can actually diagnose carbon monoxide poisoning. One is what's called a co-oximeter. So it's different than your regular pulse ox. Your regular pulse ox, like we talked about, it works on wavelengths of light, and it can't detect the change in wavelength of light with a red blood cell that's bound to carbon monoxide. However, there do exist oximeters that can distinguish a difference in wavelengths
Howard
of
12
light.
leads on the park. You
You got them? Yeah, that's good. So again, these co-oximeters, they can actually give you a carbon monoxide percentage. And in non-smokers, your carbon monoxide level is never zero, by the way. Your body's always got some. We live in too much of an industrialized world not to have at least some in your body. But it's usually in a non-smoker, maybe 3% or less, something like that. In a smoker, it gets closer to like 5 to 7% in the smokers, because you know you're inhaling carbon monoxide when you smoke. And then anything over 10% we consider abnormal. Even in a heavy smoker, you shouldn't be getting over 10% with your carbon monoxide levels. That's strange. So when I put on somebody a pulse ox on, or I'm sorry, a co-oximeter on somebody that I'm worried about carbon monoxide, if the percent level is around 6 to 7%, I'll ask them, hey, are you a smoker? Yeah, I smoke about a pack a day. Okay, well, that's probably what your percentage is then. If they're like 7, 8%, and they go, no, I'm not a smoker, I'm like, yeah, we kind of need to do some testing of your house or your environment because this is kind of concerning. And then if they're over 10%, and they're having symptoms, oftentimes those people require hospitalization once you start to get above 10%. So that's way number one. And that's the easy way of well, easy way for the patient anyway, of quickly determining if you have carbon monoxide poisoning, because it's literally like your pulse ox probe that goes on your finger. Number 2 is you can actually do what's called an ABG, or an arterial blood gas, where you actually stick a needle in like the radial artery, sample of blood, send it down the lab, and they can actually test and get exact measurements of how much carbon monoxide is in your blood.
Dr. Schneider, don't we do venous carbon monoxide testing at the hospitals, not the arterial?
I don't know.
That's what.
It's a good question. You might be able to actually.
That's what we've always done, is the venous carbon monoxide level instead of the arterial.
Whenever I
Send
test,
it to respiratory, dark green to respiratory, and they run
there
out.
does exist a venous blood gas, and you may be right, Trudy, I don't know. Whenever I've checked for it, I've always done an AVG. Yeah, look into that. You're probably right. They may be able to tell your percentage.
Yeah, we send the dark
Yeah.
green up to respiratory.
It's a little different because your venous blood has already let go of the oxygen, so your oxygen level will change on the venous blood gas, but maybe your carbon monoxide wouldn't. Yeah, you're probably right. It probably would work.
Used to be, used to have to keep it nice, used to have to ice it.
No, not for the carbon monoxide, we don't. We only do, or ice on ammonia levels.
Yeah. So maybe a VBG as well. Thinking about it, that makes sense because
I think we
there
did.
shouldn't be a reason why it would change.
Too, but we send up to the respiratory a venous blood to, or
Yeah, we've got method number 3 then.
Yeah.
So carbon monoxide, co-oximeter,
Arterial and venous.
ABG or VBG. Other lab abnormalities, as your body starts to get starved for oxygen, it'll start going into it'll start producing a lot of lactic acid as your body's tissues are getting starved for oxygen. So that's another blood level that you check, and it's very common for that to be high, just because it's common for your cells to secrete lactic acid when it's not getting enough oxygen. And you'll get an acidosis, or your blood will actually, or your fluid will actually become acidotic, too much acid because of the elevated lactate. But confirming the diagnosis should never delay treatment. If you're suspecting carbon monoxide, you start treatment immediately. 100% oxygen. Again, typically a non-rebreather. I guess that's just a little handout I found, but it really just kind of illustrates colorless, odorless, tasteless. And then you do see neurologic changes. The reason why those are some of the first ones you see is your brain uses, it's the organ that uses the most oxygen in your body. So your brain needs high doses of oxygen constantly in order to work properly. Unlike other areas of your body where, yeah, it needs oxygen, but not nearly the same amounts of concentration as your brain does. So if you start to become in a low oxygen environment, you'll see neurologic changes very early on. It's oxygen, stars, vital organs, including your heart. Your heart's probably not as far as needing lots of oxygen in order to work properly, but way behind your brain.
Dr. Schneider?
Yes.
Would you recommend if you see somebody that you know that you are almost 99% sure this is a carbon monoxide situation, like, people found in their homes and, all 4 of them are
Right.
semi-conscious or something like that, and the CO detectors are going off and everything. Would it be, so if you had, altered mental status, would you recommend just intubating that patient, put them down, and get the 100% oxygen going to them that way?
I would if they weren't providing good respiratory effort. So if they were in respiratory distress, not breathing well, then I would. If they were still breathing adequately, then it's a tough one. It kind of would depend on how they look to me. But I don't think you'd be wrong to try just 100% non-rebreather on them and see if that starts to get them turned around. If they're that unconscious, you flat out can't do CPAP in that instance because you've got to be awake and conscious. If you are semi-conscious, I think I would try the 100% non-rebreather. If you are unconscious, then you would not be wrong to intubate them and start giving them oxygen that way. It wouldn't be wrong. I don't think you'd be wrong to do that, I guess would be the answer. I also don't think you'd be wrong to try the 100% non-rebreather while you're bringing them to us. I think it's it's kind of based on how that patient looks, to be honest. I know that's kind of not a great answer, but
Yeah.
it does depend. Because you're right, I mean, if you get bad enough, I mean, you can just go into respiratory collapse, and at that point, you really do need to put a breathing tube in them to help them just by breathing, let alone breathing oxygen, just breathe.
You probably won't see any changes, though, is that not correct?
What's
Because
that?
I don't think the turnaround's very fast on,
So on,
if you go to treat, sometimes it takes like days, does it not, to get their carbon monoxide down?
so, I used to have it memorized in my head, I'm trying to think here. So if you put them on like in a hyperbaric chamber, which we don't do that very often anymore at all, only if you're like pregnant. I think in a hyperbaric chamber, you get rid of half the carbon monoxide every 30 minutes that's in your body.
But in the field, I don't think we're gonna see a marked difference with high flow of oxygen, correct?
You're right, it's probably gonna take at least 20, 30 minutes for it to start seeing a turnaround. So it's gonna take about 20, 30 minutes. But the sooner you start it, the sooner that process starts of reversing it. So the higher the concentration of oxygen you get in, the faster the carbon monoxide gets out. So they actually used to put people in hyperbaric oxygen where you actually have 100% oxygen under pressurized conditions. And you're able to flush out carbon monoxide in like 30 minutes, like half of it gets out of your body in 30 minutes, which is incredibly fast. And if you put them on a non-rebreather, it's like 90 minutes. And if you have them just breathe regular room air, it takes 270 minutes to get rid of half the carbon monoxide, something like that. I can't remember the exact numbers. I think it's 30, 90, 270. What will the oxidation side of a patient with an isolated cyanide poisoning? We'll skip that question. I don't know about cyanide. Will 100% oxygen be effective? Yeah, sorry, this was a combination cyanide carbon monoxide. Let me find the card. Okay. A woman is rescued from a house fire. She's confused, vomiting, coughing up black sputum, and is in overt respiratory distress. What could be causing these symptoms? Her sats are normal. Does she need oxygen? What about her respiratory distress? So we'll go with question number 3. She is in overt respiratory distress, being rescued from a house fire. What could be doing this to her? So,
Carbon monoxide.
carbon monoxide, smoke inhalation.
Edema in the air.
That's a big one. So edema, right? I mean, she could have been just a heat, like thermal injury to her airway. So her sats, so that's good, yeah. So carbon monoxide, cyanide, which again we didn't talk about. The cyanide can do it, carbon monoxide, and then thermal injury. Those are the 3 biggies. And then the smoke, just displacing oxygen. So I guess there's 4. But, so her sats are normal. Does she need oxygen?
Yes.
Yeah, right. Because we're worried about carbon monoxide with her. And plus, she was in an oxygen-depleted environment with all the smoke displacing the oxygen. What about her respiratory distress? So she's breathing.
Probably get worse.
What do you think about that?
If she's
It ain't
burning,
gonna get better.
yeah, if she's burning her airway, then you need to get her intubated.
Exactly right. And that would be my worry.
Because the swelling can come later, you won't get able to get in there.
Exactly right. I'd be worried, does she have a thermal injury and her airway is rapidly closing off? And if you delay, then it can close off and even the best person intubating in the world can't push the tube through. Okay. And that would actually be a good time to try to use etomidate, which, we now have available, at least I know the medics do, the CRH medics do, I know at least, that can, kind of knock her out, make her relaxed, while you put the tube in. Would be a good example to use etomidate in somebody this kind of situation. Last one's true, but anyway, but we'll talk about cyanide some other time, because the other 2 questions, I don't want to go into all the details cyanide to answer the 2 questions. Any questions about carbon monoxide specifically? Very good. That's all I got.
Thank you.
Thank you.
Good day.